on the computer. Hi, I'm Lasara Firefox Allen, MSW and menopause doula. I'm here with Dr. Marie Benkley today, and I'm going to allow Dr. Benkley to introduce herself to the crowd. My pronouns are they, them, and this is my inaugural podcast for Genderqueer Menopause. So welcome, Marie or Dr. Benkley, to the show, and please give us a thumbnail on who you are today.
Yeah. Thank you for having me. I'm so excited to be on your first podcast. And Marie's totally fine. Yeah, I'm Dr. Marie Benkley. My pronouns are she and her. I'm a naturopathic doctor practicing in Portland, Oregon, and I'm also a Menopause Society certified practitioner through the North American Menopause Society, which is now known just as the Menopause Society. And I see patients here in person in Portland, and then I'm also licensed in Washington and New Hampshire. So I see patients virtually throughout all of those three states. What else? My practice is almost entirely menopause focused, and with a particular focus on LGBTQ menopause, which I know we're going to talk all about. So I won't say more about that quite yet.
That's awesome. When I found your website, I was kind of out there on the internet looking for folks who specialize in what we do, which is, menopause for queer identified and queer bodied folk. And there just aren't that many of us. So
Mm-mm.
I was just so happy to see your website. A little bit about my background. I'm a certified doula with the menopause school. And that's Fiona Catchpole's school. And the certification process was great. I learned a lot, and I'm also a coach in training with GGS, menopause coaching certification program. So that's my background. Also, a lot of self-education, I have to admit. And a thumbnail about why I do what I do is that, as I was saying, there just aren't a lot of us out there. When I hit menopause as a genderqueer person, I did not find a lot of accessible resources, very few, if at
Mhm.
all. And the experience that I had was that I had to read everything through a filter, right? So I had to just like shut off any sort of like sense of being misgendered continually, either engaging with healthcare practitioners or, reading through books or listening to resources on podcasts or whatever it might be. I just had to like shut that part of my brain off and just consume the material and get to the point where I was like, okay, I learned what I needed to learn, digest it, and move on. And so my goal is, my mission as the genderqueer menopause coach is to take as much of that material and translate it for a genderqueer audience as possible. So
Um,
yeah, so and I'm just launching this podcast to kind of let people know that I'm doing this and that there are others doing this work. You and I have a couple of others lined up. Um, And I thought we would just dive in um,
mhm.
with the question of, what is your theory of menopause?
Okay, interesting. Um, So I'm going to approach this two ways. One, I'm just going to give like a little bit of like the medical definition because I think that'll come in handy when we're talking about some other things later on. Menopause being the basically the end of ovarian function, when ovulation stops and no further eggs are released. So marking the end of like menstruation and fertility. Usually average age is about 51 for spontaneous menopause. But there can be other causes of menopause that can occur more suddenly due to something like surgical removal of the ovaries, or if someone had certain cancer treatments like pelvic radiation or chemotherapy, those could result in a more sudden menopause. In terms of my theory around menopause or how I think about menopause, I certainly think of it as a transition time, like a transition in terms of life stages. And like many transitions, it can certainly be a vulnerable time. It can even be like a fraught time for some people. But it can also be a time of opportunity and transformation, like many transitions hold. I think they can hold like both of those things. But I often see like it kind of presented as one or the other of like, oh my gosh, it's this like hellish experience, or it's this like magical experience that we should embrace. But I think for a lot of people, it's totally both. And then for other people, it's like it's not that at all. For some people, it's like not a very significant experience. And I think like that's a big thing to emphasize, or that I want to emphasize, is that there, even though menopause is becoming more frequently talked about both in medicine and the media, it's still like a very limited narrative. When really, like, the truth of it is that there is such a diversity of menopausal experiences. And that's something that I'm really passionate about, is like expanding the conversation and dialogue around menopause to be really inclusive of that like diversity of menopausal experiences.
Absolutely. Yeah. I agree with that so much. I personally definitely had both experiences. For me as a genderqueer person, menopause was very gender affirming in many ways. I hadn't realized to what extent menstruating had been dysphoric for me until
Mhm.
I stopped. And then I was like, oh wow. you know, um, and I know a lot of people do know how, like, my kiddo's non-binary trans
Mhm.
identified as well, and they definitely had a more intense like dysphoric response to their menstruation. They had gender affirming surgery and no longer menstruate, so that's great for them. I just was not clued in until it stopped as to how intense the sense of like hijacking my system was.
Mhm.
um and so that was really an amazing kind of like part of my menopause experience, was that element of like gender affirmation that happened for me. Um, and then there are all the points that are less delightful to deal with, like the aching joints and the, um, you know, all of the varied symptoms, drop in libido, name them, I experienced it. So, the next question that I have is, what inspired you to focus specifically on menopause in your practice?
Yeah, like I said before, it's like, yes, it's becoming more talked about both in like the medical field and in the media, but it's still an area of health that doesn't get much attention, is misunderstood, is stigmatized. Um, certainly for queer and trans people experiencing menopause, but even for cis women experiencing menopause. So that was part of it for me. There's so much confusion and misinformation and outdated information. And so I was really drawn to it in that way, that I'm like, okay, this is such an important area of health for so many people. And yet, it's I think a lot of doctors say this, that in medical school, we got like maybe half an hour of one class on menopause for like the whole 4 years, and that was it.
Right.
And so, like, your primary care physicians are awesome. They're wonderful. They have to do so many things and have to be good at so many things. But just because of that, they usually don't have the training to really adequately serve people in menopause. And so, yeah, so all of those reasons really drew me to it. And then it was also just like the patients who showed up in my office. Like when I
Mhm.
graduated school, I didn't know that I was going to, be focused in menopause. It was really when I was out in practice. Um, and people were coming to me and I was like, oh yeah, this is like, I love this. This is what I want to do. This is like what is needed. And then just from like a naturopathic perspective, like naturopathic medicine is really integrative. It's really like holistic and comprehensive. And menopause care is an area that like needs such comprehensive care, because it's like, okay, yes, how are you feeling right now? How do we support you feeling better right now? But also, like, how do we think about support your like bone health, heart health, mental health now and long term? It's just like it encompasses so many areas of health, um, beyond just the like, let's treat your hot flashes or, low libido, even though that's important too.
Yes, absolutely.
Yeah,
100.
and then like in terms of queer menopause for me, like I'm a cisgender woman, so I don't have an experience as like a trans or non-binary person, but I am queer and I'm definitely situated within queer community, and so just that became like really an area of focus for me, of like really wanting to serve queer patients and serve like my queer community. Um, yeah, and even just like as thinking about like these narrowed narratives of menopause, like certainly certain like narratives apply to me as like a cisgender woman, but other narratives of like being straight or like having children or this or that don't apply to me. I'm like, I'm queer, I'm like poly, I've chosen not to have children, like all of these things where I'm like, okay, that sort of like picture of the menopausal woman does not fit my experience. And so
Right.
again, just going back to the like really wanting to expand this dialogue around encompassing all of the vast diversity of menopausal experiences.
Definitely. Thank
Yeah,
you.
so I said a lot of things there, but
No, you
a
hit
lot of
you
a
hit
lot
two
of things brought
questions
me
in
to this
one,
work.
so that was great. Yeah, that's amazing. The next question I have is about gender affirming hormone therapy. For those who are listening who may not understand how gender affirming therapy, hormone therapy works, can you give us kind of a 101, like what is it and how does it work? And then I'll have a follow-up question on that.
Yeah, for sure. Yeah, and also like if you have any thoughts on anything, feel free to jump in. I'd love to hear your perspective too. So yeah, for gender affirming hormone therapy, sort of like a simple definition is when someone takes exogenous hormones, and what exogenous means is like hormones that are not made in the body. You're like taking a hormone to cause body changes that align more with their gender identity. And so like the two main categories would be we have like estrogen gender affirming hormone therapy and testosterone gender affirming hormone therapy. Sometimes they're referred to as like feminizing hormone therapy versus masculinizing hormone therapy. I think that's a totally fine way to refer to it, but I just want to emphasize that like hormones themselves aren't gendered. Like everyone has all of these hormones. We just have them in different amounts. So sometimes I use the terms just like estrogen hormone therapy and testosterone hormone therapy. But that's the sort of like brief definition of gender affirming hormone therapy. But yeah, if you want to add
Beautiful.
anything to that, please do.
Yeah, I love that you refer to it as estrogen and testosterone hormone therapy rather than the gendered terms. I love that as a non-binary trans person. Um, I also had an experience where when I was in menopause and I was like having all these symptoms and I did not necessarily want to go on estrogen. I was excited about not having estrogen running the show anymore, honestly, at that moment. I am on estrogen now and it's very helpful, but at the time I was not ready for that. And I went to Planned Parenthood as a trans non-binary identified person and asked for testosterone therapy. And I found a practitioner who would provide that for me as a non-binary person, which I was very pleased with. And so I did testosterone therapy as my first menopausal hormone therapy.
Mm-hmm.
And it was very, very helpful for the things that I wanted it for, which was specifically the joint pain, the low libido. It didn't take care of it comprehensively, but it did help. And a number of other symptoms that I was having, like memory issues. It helped with the memory issues I found, which was interesting for me. I don't know if that's across the board, but I think it's so helpful to have an array of different possibilities for hormonal therapy, whatever stage of life you're in. And I look forward to the day when testosterone is treated as a reasonable prescription for as part of the
Mm-hmm.
menopausal package, which I know it is in other countries. Not all other countries, but I know in Australia and the UK is verging in that direction too.
Yeah.
The US is like so freaked out about gender that we're very slow to adopt that mentality, but it'll happen sooner or later.
Yeah, and I think that's just important to clarify since we're talking about hormone therapy, like the gender affirming hormone therapy versus menopausal hormone therapy, which is also hormones,
Yeah,
but used to treat menopausal symptoms. And like you mentioned in the US, like right now, the primary menopausal hormone therapy is estrogen and with a progesterone if someone has a uterus. And testosterone therapy is usually only being used to treat low libido right now, at least in the States, in terms
right.
of menopausal hormone therapy.
Yeah.
But yeah, we can talk all more about that too.
Yeah, well, so my next question that I had was, and I'm just so curious about this as a practitioner as well, because
Mhm.
there's so little information out there about this particular question, and I'm very excited to talk with you about it. So, transmasculine menopause.
Yes.
What does hormone therapy for trans masculine folks, how does that affect menopause, if at all?
Mhm.
And and then there are other questions that I have about atrophy and
Yeah. Yeah.
no.
Yeah, I think, okay, the easiest way to talk, like breaking this down into probably 3 categories, depending on like if someone is taking testosterone therapy for gender affirmation and what dose, because that will really
Yes.
affect the menopausal experience. So for someone who is transmasculine taking what's like considered a like full or typical dose of testosterone therapy for gender affirmation purposes, if someone started that in their 20s and 30s, before like the typical average age of menopause around 51, it's like totally possible and likely that menopause itself like won't really be a relevant experience, or like won't be a time of like having menopausal symptoms, because that dose of testosterone therapy that they're taking has already suppressed estrogen production. So estrogen production is already low.
Right.
Um, that said, like when someone starts testosterone therapy at that typical dose, they might have like menopause-like symptoms upon starting the testosterone therapy, things like hot flashes, because the testosterone therapy results in a low estrogen level. Usually that resolves with time as the body just adapts to the new like hormonal status. I call that a menopause-like experience. I know some people might actually like identify that as menopause, and I don't want to dismiss that at all. The reason that I use that term was because for most people, if they were to stop testosterone therapy, especially if they're younger, like in their 20s and 30s, ovarian function would very likely resume. Whereas with menopause, ovarian function ends and it wouldn't resume.
Right.
Um, yeah, so that's with someone on the full dose of testosterone therapy. Do you have anything you want to add about that?
Yeah, I mean, I think the dose specificity part is so
Mhm.
important, and that, I mean, I know I have witnessed many people on varied doses of testosterone having different menopause-like symptoms. So, I've definitely seen that. And then I've seen folks on lower dose that it doesn't phase their estrogen, levels at all. Because, as you know, our bodies already balance all of those hormones ongoingly anyway. So like micro supplementation of testosterone, for example, which is not uncommon across the world,
Mhm, mhm.
isn't necessarily going to have the same impact as a full um, dose.
Right, yeah, so there's definitely a difference with, like, those microdoses of testosterone, and I think generally how, like, it's defined as, like, a typical full dose of testosterone therapy usually results in blood levels that are, like, the same as a cisgender, man's range of testosterone therapy versus, like, a microdose, it's, like, higher than what a gender woman would have, but lower than what a cisgender man would have, so it's kind of in that mid-range. And that like may suppress estrogen production. It may not. It may result in estrogen production that's like lower than a cisgender woman, but higher than a cisgender man. And so with that, because there's still potentially some estrogen production, someone may still have a perimenopausal menopausal experience that has like menopause symptoms.
Right, right.
Yeah.
Or conversely, someone may just continue having regular menstruation, just like as if they weren't supplementing at all.
Right. Right.
It's like,
Yeah.
and it's so body to body. And I think that's one of the things that people don't really realize,
Hmm.
how like specific to your physiology,
Hmm.
whatever, you know, hormonal pharmaceutical answer is going to be. It's going to
Hmm.
be specific to your body. And so I think that that's one of the reasons too that I'm excited about more flexibility around how we treat, different stages and different desires, like gender affirmation measures for folks that were non-binary 10 years ago were not an option, really. in the medical community as much. And now, I can go to a Planned Parenthood in a rural community and say, I'm non-binary and I want gender affirming care, and I can get it. So, we've come a long way, and there's still a long way to go, but we've made strides, and so that's great.
Yeah.
Treating atrophy. Treating
I
atrophy.
had one more thing.
Oh yeah, go for it.
Yeah. So then there's the other thing. So we have like the doses of testosterone. And then for someone who like is transmasculine, non-binary, who's not on hormone therapy, we would likely expect the menopausal experience to be similar potentially to a cisgender woman. And could have the same like perimenopausal symptoms.
Right.
Yeah.
That brings up an interesting question too. Which is, if a person is transmasculine, non-binary, not on testosterone, and has gender affirming surgery to remove the uterus, how might that affect one's menopausal?
Oh, yeah. I think it really depends whether the ovaries are intact or not. And so if there is a hysterectomy where the uterus is removed and one or both ovaries are intact, then those ovaries like are still able to produce estrogen even though the uterus isn't there. Um, and so that probably would be a pretty similar experience to someone who still has their uterus, except there wouldn't be menstruation because the uterus isn't there.
Right.
That said, if someone were to have both ovaries removed with the uterus, then they're no longer having a source of that estrogen production, in which case they would need either estrogen therapy or testosterone therapy for like long-term health reasons for like preserving bone mineral density.
That's interesting. That brings up an interesting, I have a client who had a surgical experience of menopause.
Mm-hmm.
She is BRCAA mutation positive individual, and she elected, because she had lost multiple generations in her family to ovarian or uterine cancer.
Mm-hmm.
And so she elected to have a surgery, and she was not given good resources by her medical professionals. And many years later, she's still like finding her way through what is, what's best for her in this situation. She was told at the time that because her mutation is estrogen sensitive, that she's not eligible, or she's not a good candidate for estrogen therapy. So, but she wasn't given other options.
Mm-hmm.
So it's interesting that you bring up the testosterone option as an alternative. And I'm wondering, in the case of someone with a BRCAA mutation, what off the cuff, like, I'm not taking this as medical advice, but what would be the best solution there?
Yeah, I think, well, in the case of like a transmasculine person, that would be like testosterone therapy at the full or typical dose, which likely, wouldn't be, if this is a cisgender woman, probably wouldn't be an option for them because they're not looking for testosterone
Masculinization,
gender
right?
affirming for yeah. And so I don't think we have, as far as I know, we don't have I think there's some people looking at some researchers looking into this, but we don't have robust enough data yet to say that like a lower dose of testosterone therapy is adequate for something for like maintaining bone mineral density. I hope that we get that though, because that would potentially, if that's considered a safe option and we find that it preserves the bone mineral density at a low dose, that could be a really potentially great option for someone beyond doing something like a bisphosphonate therapy for osteoporosis. Yeah, so I don't really know the answer to that.
Okay.
But what I was referring to before was like, okay, testosterone therapy at that full typical dose.
Yeah.
We know that adequately preserves bone mineral density in a like a trans manner, not in binary person who's on that full dose.
Okay. Perfect.
But
Good.
for that case, for that cisgender woman, we don't really have a robust data
Not
enough
a
to
lot of
do that.
options.
Yeah.
Yeah. Okay, well, thank you for that answer. That's helpful for me.
Yeah.
So yeah, next question that I have is treating atrophy and staying away from gendered terms for anatomy here, but genital anatomy,
Mhm.
atrophy, which interestingly can also be a side effect of testosterone therapy. And so when I was given testosterone therapy, they did give me vaginal application of estrogen,
Mhm.
and which I found to be very helpful.
Mhm.
And then when I stopped using the testosterone, the they took that off the table too, unfortunately. I
Mhm.
should have kept using that throughout the whole
Mhm.
time. Um, and I just recently started using that application again, and it has been incredibly helpful. So, what is your like when you're dealing with, like, let's say any person in
Mhm.
menopause, what is your frontline therapy for prevention or treatment of atrophy?
Yeah, for treatment, I would say for sure vaginal or genital estrogen. For sure. Like it's so helpful. And what I like to emphasize about with that type of vaginal application is that it's very low dose and it's localized to that area. So it's not a systemic hormone therapy that's traveling throughout the whole body. So even someone who is on testosterone therapy for gender affirming purposes, I really like to reassure them that like an application of that, genital estrogen is just localized to that pelvic area. So it's not, not traveling throughout the whole body. It's not going to reverse any of the changes of the systemic testosterone therapy. And it's by far the most effective therapy for treatment of like genital atrophy. Yeah. So I'm a huge fan.
Yes, I am too. I'm a huge fan.
Um,
And I think I think there are folks that don't know about that as an option, and how like benign it is, and how localized it is, and how safe it is. And I think that, all the research that I've done on it, and all of the anecdotal stories that I've heard, it just works so well for so many people. The only hesitation is for folks who have dysphoria. I have spoken with folks where that's just not an option,
yeah.
because they don't want to engage with that part of their body.
Hmm.
And so that is also a thing that I am, conscious of, and wonder if what other options there might be in that case, and also wonder about for prevention what you might recommend.
Hmm. Yeah. If it's dysphoria in the sense of like using an estrogen causes dysphoria versus like I don't know, touching that part of their body, I would probably recommend some sort of like vaginal or like genital moisturizer, like a hyaluronic genital moisturizer is pretty effective. So probably just like another product to use in that area of the body if like it's the estrogen part that's causing dysphoria. Um, I would say most of those treatments are used more for treatment than prevention, but like a moisturizer could be used as prevention too. I'm trying to think of what other options there would be. That would probably be the main one that I would go to. You
So
know,
moisturizers and lube
like
when
a moisturizer, lubricants, other
Mhm.
sorts of products to use in that area of the body if it's like the estrogen part that
Right.
is causing dysphoria for someone. Because
Okay.
what's going to be the most effective is using a product like in that area of the
Yeah.
body. And so I would just choose it, like you said, like moisturizer, a lubricant during sexual activity. Those are all both helpful for sure.
Great. I've heard about one other possible
Oh, there
application,
is
and I'm
there's
trying to,
DHEA.
yes, DHEA.
So that could be a good, yes, thank you for reminding me of that. There is DHEA. So that could be used for that purpose too. So that might be another option if someone doesn't want to use estrogen.
Nice,
Yeah.
beautiful. Love it. Um, Okay, well, those are the topical questions that I have, but I have another question which is left over because we both share. But
Yeah.
before we go there, I want to make sure you don't have any last thoughts about menopause that you wanted to
Yeah.
get out there that you didn't get a chance.
I I have some thoughts yeah, more about testosterone therapy. So, yeah, let me think about this. With And I mentioned this before. So like with testosterone therapy, really the only like evidence-based use in the United States for cisgender women is for treatment of low libido that's related to that's not due to like other medical causes. That said, like certainly anecdotally, we hear of testosterone therapy helping with energy or mood or things that you mentioned. Um, but we don't like have enough of like research on that yet. I really hope that changes. And I agree with you. I think part of that is like, I don't know, we like see
Phobia.
hormones it's gendered in the US. And so testosterone isn't studied enough for women. There's probably something like that going on.
Yes.
Um, and there has been like one, like, it's not a really high quality study. There's one like open label study. And what that means is that it was a study on cisgender women. They were giving testosterone therapy. Open label means they knew what they were getting. All of the researchers knew what they were getting. And they tracked menopausal symptoms, things like hot flashes. And they reported that they saw an improvement in menopausal symptoms, including hot flashes, with testosterone therapy. I don't think we can like take that and run with it and say that like testosterone therapy for sure treats all menopausal symptoms like hot flashes, but I do think that gives us a reason for sure to further look into it and do more robust studies to get evidence to see like, okay, does testosterone therapy help with menopausal symptoms? Um, in the same way or similarly to estrogen, especially for people who can't or don't want to use estrogen, maybe that would be like an alternative option. But I just want to be honest about like what research we actually have and what we don't have. But that's potentially suggestive.
Mm-hmm.
So, and then I think the other thing to consider is for people who aren't on testosterone therapy. So let's say someone is in that perimenopausal age range and having symptoms and considering testosterone therapy for gender affirmation purposes. If they were to go on like the full dose, typical dose of testosterone, that would essentially like probably like speed up the perimenopausal experience in a way because it would probably result in like a quicker cessation of menses. So I think that's just something to consider for someone who is like in perimenopause but also considering testosterone therapy for gender affirmation purposes.
Mm-hmm.
With the like lower dose testosterone, like the microdose levels, it like might help with some menopausal symptoms. Like you mentioned, you did for yourself, but for other people, it may not. And so we
Right.
really just like don't have enough data to say for sure, like, yes, this will for sure help with this. Although anecdotally, it certainly has helped some people. And if someone is considering it for gender affirmation, I think for sure it should be offered. Yeah. So
Great.
I think there's just like, yeah, it's just really interesting looking at that overlap of potential hormone therapies in that sort of midlife range when someone is considering hormone therapy, both for treating menopausal symptoms and for gender affirming purposes.
Definitely. Definitely. Thank you for adding that. I appreciate it. Um, so before we wrap up, I just want to bring up weight training,
Oh, yeah.
because you and I both are in different areas of that sport.
Mhm.
Um, I am in bodybuilding and you are in powerlifting. And so I just wanted to talk about that for a minute. I saw one of your reels today.
Oh, yeah.
Yeah. Good job.
My
Uh,
deadlift. Oh, I love powerlifting.
yeah. Awesome. When did you
Um,
start?
I started 2.5 years ago, so not that long ago.
Right.
I had never touched a barbell before then, so relatively new to it. I absolutely love it, and it's so cool to see like how strong I could get and how much muscle I can build just being consistent with something over a couple years.
Yeah, totally.
Yeah. So like I got into it for that purpose, like those sort of like wanting to get stronger, wanting to build muscle. And then of course, like I think about the long-term effects of like preventing bone loss or osteoporosis, preventing sarcopenia or like age-related muscle, supporting like all of those long-term health benefits too. But also it just like feels fucking awesome to get strong.
Yes, 100%, 100%. And
Yeah.
that, that is so I only started, I mean, I trained when I was younger,
Mhm.
but I haven't for decades. And I started I started bodybuilding just in August. So it's only been like just over half a year. And yeah, my gains, like my strength gains, my capacity gains have been just so remarkable, and I'm getting stronger. And my whole goal was one, I love camping by myself. I love solo camping. I love hiking. I love being outside. I love going on road trips by myself. All
Mhm.
of these things are things I want to be able to do until I die, literally.
Yeah.
And so I don't plan on relinquishing my strength as a byproduct of aging.
Yeah.
I think that we're capable of a lot more. And I've seen, there are some really, really strong older folks out there that, and by older, I mean in their 90s,
Yeah.
you
Oh,
know, who are,
I want that to be me.
yes, exactly. So it gives me a goal when I look at these folks and see them just working so hard and keeping their bodies active and lithe and able-bodied. I want that. I want that. And so that was
Yeah.
my motivation. And I am, just for the heck of it, planning on doing a competition, just once probably,
Oh yeah.
just for the heck of it. But
Yeah.
so yeah, what about the place of lifting heavy shit in menopause? What is
Oh,
the
I think
relationship?
it's great for everyone.
Yeah,
Um, yeah, I think there's so many things that's helpful with. I mean, just like the having that all those like longevity purposes in terms of like, okay, if you have muscle mass, it's gonna when you get older, one, you'll be able to just I mean, we think about wanting to hike or do all those things, but even the simple things of like doing the activities of daily living around your house or like being able to like get up from a chair or just like things we don't think about as much, having more muscle mass will support you being able to do those things longer. And then just doing the like any sort of weight bearing activity helps bones. And so I think about that a lot because in menopause, that's a time, especially if someone's not on any form of hormone therapy, we lose a ton of bone mineral density at that point, which increases the risk of osteoporosis, which increases the risk of fracture, which could be like a huge impactful event in someone's life.
yeah.
Um, yeah, so there's so many things: metabolic health, cardiovascular health, mental health. For me, it helps my mental
Mental
health
health,
so much.
yes, absolutely,
So
100%.
much. Yeah, so I certainly encourage everyone, but particularly people in menopause.
Yeah,
Yeah, because it's a time like we see changes in our health as we age, but because menopause, there's such a huge change in hormones during that time,
yeah.
we see a faster change in things during that time. Like we see a huge drop off in bone mineral density in the couple years after menopause. And so that because of that hormonal change, there can be a bigger shift in things at that point in time.
It's
Yeah.
very dramatic. It's very
Yeah.
dramatic. And, I mean, honestly, like, I mean, I've seen myself, it's like the aging process
Mhm.
accelerates for a while, right?
Yeah.
And then and one of the things a delightful byproduct of bodybuilding for me has
Mhm.
been like watching myself age backwards a little bit, which has been really nice.
Mhm.
Just like my skin looks healthier, like my body is more, I have more self-efficacy, which makes me walk differently, it's just like all of these,
Yeah. Yeah.
incredible effects. So,
Yeah.
and it doesn't have to be bodybuilding or powerlifting. It can
Yeah,
be
it's something you
whatever people
yeah,
want to be doing. But the point is stay active, lift heavy stuff, keep yourself, present in your
yeah.
body. And like, I think there's like this cultural thing around, just accepting aging
Mhm.
and, and I'm accepting my aging, but I'm not gonna roll over and
Yeah. Yeah, I think that is yes. Yes. I think that's such an important, like, I think there's, and especially in like the naturopathic medical field, there's a lot of like anti-aging medicine. And I'm like not aligned with that at
Yep.
all. I'm like, we age, like let's embrace aging, but no, we don't have to just like roll over and
Right, right,
oh,
exactly.
yeah. And the other thing
Exactly.
I wanted to say, since I'm like, I identify as a femme person, and for me, there's something that I love about powerlifting of like having like lots of muscle. And like, I work with a lot of femme queer people or cisgender women who are like really fearful of getting bulky still. And I
Hmm.
just want to like, I don't want to tell someone to get bulky if they don't want to, but I
Right,
also just want to say that getting bulky is totally hot. And you
right,
can be femme and bulky at the same time.
right. And it's also harder to get bulky than you think it is.
It's hard. It is hard. It is definitely hard. So
You have to work real, real hard to get bulky, especially after menopause. I'm
I
like
know.
3 years
So
after
it's not
menopause,
gonna,
and I'm
yeah,
like,
you're probably not even bulky. Yeah.
please let me get bulky. That's my whole goal right
That's the thing.
now.
I'm like, please let this happen. Let me get bulky.
Totally, totally.
Oh.
So, last words of wisdom. Do you have any parting words? And then also, of course, let's share our socials so people can,
Yeah.
yeah.
Oh, parting words of wisdom. I should have thought about this before. Hmm.
Well, you can share your socials and then you can
Yeah,
have
if something
parting
comes,
words.
or maybe you can share something and they'll, yeah. So like I said before, I practice in Portland, Oregon in person. You can find me at drbenkley.com, which is drbenkley.com. You can find all the scheduling information there. And I also can see patients virtually. And I'm on Instagram at Dr. Marie Benkley. So come say hi.
Cool. And I am on Instagram at genderqueer.menopause. And my website is genderqueermenopause.com. And folks can find me there or on Instagram. Feel free to hit me up either way. And oh, I also have a Facebook, Genderqueer Menopause page on Facebook. So wherever people are, I'm there. I think I'm going to start a TikTok too, but we'll see.
I
I
have a
know
Facebook, but I never use it. So don't look at it.
too many things, too
I'm
many
impressed that
things.
you could do, all four.
Um, so yeah, I mean, my last, words for this episode are just thank you for being here. Thank you for sharing your words with us. And, thank you for what you do for our community. Like I said at the beginning, there just aren't that many of us out there. And so, I'm grateful that you are doing what you're doing, and I'm sending people to you already. So
Awesome.
yeah.
Well, yeah, I'm grateful you're doing what you're doing too. And it's like awesome connecting to other folks who are doing this work. Yeah, makes me so excited.
Awesome. Well, we'll have you back later on, in some later episode, and we'll have another session, another
Cool.
opportunity to talk about what the new developments are in the next,
Awesome.
year or whatever. But it's been a delightful time to talk with you, Marie, and I really appreciate you.
Awesome. Thanks so much for having me.
All right.